Hi everyone, I know this is going to be a topic that touches so many people because if you're seeing it from a civilian's perspective, you may think like as if I'm talking about the abortions that we refer to when people are advocating for the laws for or against abortion. Grab a piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we'll look at abortions on the medical side, not really the legal side. If you haven't yet subscribed to the channel, please subscribe to the channel, hit the bell notification icon to be receiving notifications of such videos every time I post. Grab a piece of paper, grab your pen, and let's go. So when you talk about an abortion, in medical terms, this is just simply loss of a pregnancy before 24 weeks of gestation, which is deemed as the age of viability. This is according to the UTH Obstetrics and Gynecology Protocol, or loss of an embryo or a fetus weighing less than 500 grams. So remember that these spontaneous abortions are going to be accounting for the most common cause of early death and early pregnancy loss, and most of them are usually fetal in origin. Now, when you look at the term abortion on a layman's view, they're going to refer to as elective termination of pregnancy, which is not what we're talking about here. We're talking about something that happens spontaneously here. So if you actually look at it in medical terms, we can actually use the term to describe a miscarriage before 24 weeks is also referred to as a spontaneous abortion. And remember that the embryo and the fetus is called the abortus. Whatever has been expelled is referred to as the abortus. Now, here are some important numbers. Approximately about 10 to 20% of the pregnancies result in spontaneous abortions. 10% of them are actually illegally induced. 75% of them occur before the 16th week of gestation. And of these, 75% of them occur before the 8th week of pregnancy, actually. So here are the types of abortion that we'll look at. So we'll look at the spontaneous type, which I also refer to as the miscarriages. And they can also be induced anyways. They can be induced legally, that's medical termination of pregnancy, or they can be induced illegally. Now, these ones that are induced illegally have a risk of actually becoming septic. They have a risk of being infected. Under certain circumstances in the Zambian law, abortion is legal under certain circumstances, like I told you. You can actually do your own research, read up on the laws of abortion after this video. If you really want me to do a video on the laws of abortion, please just comment in the section below and we'll review the law on abortion and what actually it means in Zambia, and if it is actually legal in Zambia and when is it illegal. Then what we're going to be focusing here are those that occur spontaneously. So they can either be isolated incidences, so they could be sporadic, or they could be recurrent. Now remember that these are going to be of many different variants. They could be threatened abortion, inevitable abortion, complete abortion, incomplete abortion, missed, as well as septic abortion. So what are some of the causes? Of the bulk majority of the causes are going to be attributed to genetic and chromosomal abnormalities. So most of them are going to be causing early miscarriages. About 50% of them are due to autosomal trisomies with, of course, Down syndrome or trisomy 21 accounting for 50% of the cases. Trisomy 16 accounting for 30%. And remember that the trisomies are accounting for about 50 to 60% of the cases. You could sometimes also have monosomy X, which is Turner syndrome, 7 to 15%. So this is actually the single most common chromosomal abnormality in miscarriages. You could have polyploidy, which is having three or more multiples of haploid numbers of chromosomes. For example, 69 or 92. Triploidy is in 15%. Tetraploidy is in 10%. Of course, you can only know these things if you send the abortus for karyotyping, and it's actually advised that you send the abortus for karyotyping. Then structural chromosomal rearrangements, that's 2 to 4%. These include translocations, deletions, invasions, and ring formation, and other abnormalities like mosaic, double trisomies, and others account for about 4% of the abortions. You may also have endocrine and metabolic factors that are accounting for 10 to 15%. You may have a luteal phase defect. So this is going to be resulting in early miscarriage, as implantation and as well as placentation are not really going to be supported adequately. You could have a progesterone deficiency as a result from the corpus luteum or poor endometrial response to progesterone. You have other conditions like polycystic ovarian syndrome, diabetes, largely uncontrolled diabetes, hyperthyroidism, as well as hypothyroidism. Structural abnormalities account for 10 to 15%, so you could have cervical incompetence, which may be congenital or acquired. This is actually one of the commonest causes of mid-trimester as well as recurrent abortions. You may have congenital malformations of the uterus like a septate or a biconjugate uterus in about 25 to 30% of the cases. These result in mid-trimester abortions. And of course, this is because there is actually reduction in the volume inside the uterus. And this reduction is because of this extra tissue and the reduction in expansibility of the uterus, and of course reduction in the placental vascularity, of course if the placenta is implanted on the septum, as well as increased uterine irritability and contractility. You may sometimes have leiomyomas, which are fibroids, submucosal type. These are going to be causing distortion or even partial obliteration of the uterine cavity. Other causes are going to be things like a decreased vascularity at the implantation site. The fibroids can undergo what is known as red degeneration. We talked about it when we reviewed fibroids. You may also have increased intrauterine irritability. You may have intrauterine adhesions, synechia, or Asherman syndrome. This is, of course, from a previous curettage, and this may actually interfere with implantation. It may interfere with placentation. It may interfere with fetal growth. Now, this depends on the severity of the adhesion, of course. With total types of adhesions or Asherman syndrome, even corporal or even cervical ischemic patients, they suffer from amenorrhea, hypermenorrhea, infertility, or even sometimes recurrent abortions. Infections account for 5%, and these may affect the cervix, they may affect the uterine cavity, they may affect any of these structures, or even the seminal fluid can actually cause abortion, infections in the seminal fluids. They may be viral in nature: herpes, rubella, cytomegalovirus, variola, vaccinia, HIV. They may be parasitic in the terms of toxoplasma, malaria. They may be bacterial in the terms of ureaplasma, urealyticum, mycoplasma hominis, listeria monocytogenes, chlamydia gonorrhoeae. You may have brucella, spirochetes. Of course, these are hardly a cause of abortion before 20 weeks because of the effective thickness of the placental barrier. And the infections sometimes can be asymptomatic. In 5 to 10% of the cases, there are immunological factors, autoimmune diseases. So you may actually find antibodies against the placenta. You may find antibodies including the antinuclear antibodies, the anti-double-stranded antibodies, the anti-phospholipid antibodies, including the lupus anticoagulant, as well as the anticardiolipin antibodies. And remember that the spiral arteries and the placenta intervillous thrombosis, as well as placental infarction and fetal hypoxia, may be seen, and these ultimately are what is going to lead to the abortion. Then with anticardiolipin antibodies, this is just simply a common cause of early pregnancy loss. So some women with SLE actually are going to be producing antibodies against their own vascular system and their own fetal placental tissues. So this is known as an antiphospholipid syndrome. So the treatment is usually with subcutaneous heparin. We may sometimes have some allogenic diseases like paternal antigens. This one is a very interesting thing. For example, a patient gives birth and they are with a certain man, then they switch the man, and when they now attempt to get pregnant with this new man, they actually fail. Why is this so? It's because the paternal antigens are going to be recognized as foreign, and they may actually invoke a protective blocking antibodies in the mother. So these blocking antibodies actually prevent the maternal immune system from recognizing the fetus as a foreign entity. So the fetal allograft that's going to be containing now the paternal DNA, paternal antigens are not going to be rejected normally. But then the paternal human leukocyte antigen sharing with the mother leads to diminished fetal-maternal immunological interaction and ultimately fetal rejections, which can actually even happen when someone changes partners. You may also have anti-fetal antibodies Rh negative women with anti-D antibodies, and of course the T helper 1 cytokines, the interleukin 2 and interferon gamma, are the ones that are going to be causing all this disaster. And then the T helper cytokines, interleukin 4, 5, 6, and 10 are not going to be involved. There's going to be downregulation of the T helper 1 cytokines by the progesterone, and this may actually improve the fetal outcome. And then activation of the natural killer cells actually may damage the placental trophoblastic cells, and this can actually result in an abortion. Other causes include medical illnesses of the mother, like cyanotic heart diseases, hemoglobinopathies, blood group incompatibilities, for example, an incompatible ABO blood grouping. You may have Rh incompatibility. These have now become quite rare. So a couple with a group A husband and a group O wife have a high incidence of abortion for some reason because of the same different blood groups. You may also have premature rupture of membranes. You may also have some paternal factors. So the sperm chromosomal anomaly translocation can actually cause miscarriages. So some women who actually miscarriage recurrently may actually have normal pregnancies following them getting married with a different man or a different individual. You may have thrombophilias. This may be inherited thrombophilias. You may have protein C resistance. You may have factor V laden mutations. You may have protein C deficiency and even hyperhomocystinemia. Environmental factors that have been implicated and may not necessarily cause abortion, but they may contribute, include things like tobacco. Smoking more than 14 cigarettes per day increases the rates of abortion. Remember that once you smoke, you increase the formation of carboxyhemoglobin in your blood, and this decreases the oxygen transfer to the fetus. You may also have alcohol, irradiation, X-ray exposure, environmental toxin exposure, caffeine, especially getting more than 5 cups a day, trauma, contraceptive agents like intrauterine devices in situ. You may have drugs, chemicals, noxious agents like anesthetic gas, arsenic, aniline, as well as lead and formaldehyde. Then this, sometimes in most of the cases, it's unexplained and we don't really know what the cause is. So here are some common first trimester causes of abortion. So remember, the genetic factors are by far the most important cause and the most common cause, followed by endocrine factors. You may have immunological disorders, infections, and in most of the cases they are unexplained. Then here are some common causes of second trimester abortions. These are pretty much anatomic abnormalities like cervical incompetence, Mullerian fusion defects like a boy conjugate, and even septate uterus, uterine synechia, uterine fibroids. It could be maternal medical illnesses, or they could also be explained in the bulk majority of the cases. What are some of the risk factors? Remember, in obstetrics and gynecology, you having the condition generally predisposes you to have the condition again. That's from just my past experience. So the previous history of spontaneous abortions, increasing maternal age, an increase in the parity, an increase even in the interval outside the range of 12 months to 36 months. So it means if the spacing is outside this normal range of the pregnancies. Then smoking, alcohol, and radiation. Now, what's the pathophysiology that's going to be happening in terms of abortions? Remember that in most of the cases, it's going to be due to the early pregnancy failing to actually inadequately form the placenta, or placentation is not going to be adequately happening. Now, remember that for this to actually happen, there should be some certain changes that happen in the uterus. The spiral arteries are supposed to become much more tortuous. They're supposed to be increasing in their size so that they can deliver more blood towards the uterus, and more oxygen could be delivered to the child. But also, in addition to this, the trophoblastic tissue is supposed to invade into the decidua towards the spiral artery. So there is a defective transformation of the spiral arteries, and even a reduction in trophoblastic penetration into the decidua and into the spiral arteries. So this defect of placentation actually becomes much more pronounced in chromosomal abnormalities, therefore leading to abortions. So in the early weeks, remember that death of the ovum occurs first, then it follows expulsion. Then in the later weeks, the maternal environmental factors are actually involved in leading to expulsion of the fetus, which may actually have some signs of life, but is actually too small to survive. So if it's before 8 weeks, the ovum, which is going to be surrounded by the villi with the decidual covering, is actually expelled quite intact. And sometimes the external os may actually fail to dilate, such that the entire mass is going to be accommodated in the dilated cervical canal. You refer to this as a cervical miscarriage. Then if it's between 8 to 14 weeks, the expulsion of the fetus actually commonly occurs behind the placenta and the membranes. A part of it actually may even be partially separated with some brisk hemorrhage or even remains totally attached to the uterine wall. Then beyond 14 weeks, actually, the process is quite similar to that of labor. So you can think of it as a mini labor, where the fetus is actually expelled first, then followed by expulsion of the placenta after a varying interval. Now, what are the clinical presentations that we have of abortions? So in our history, it's very important to ask for a history of vaginal bleeding. It's very important to ask for a history of amenorrhea. It's very important to ask for a low abdominal pain and get a pregnancy test. There should be at least a positive pregnancy test. Then other factors pertinent to the history are the maternal age, the medical disorders that may be present, and even a previous history of miscarriages. And these are the clinical entities that I want you to keep in mind: threatened abortion, inevitable abortion, complete abortion, incomplete abortion, missed abortion, and a septic abortion. I think how I arrange them in this manner makes it very easy to actually think about. So a threatened abortion could easily convert into an inevitable abortion. An inevitable abortion could either be complete or incomplete. Then sometimes you may have a missed abortion. And in all these, it may actually become infected and then becomes a septic abortion. So it's very easy to actually think of them in that manner. So we'll begin with threatened abortion. So this is someone who's going to be having vaginal bleeding before 24 weeks of gestation in the presence of a viable fetus determined by ultrasound, but the cervix is not dilated. So it's like the pregnancy is still there. It's just threatening that you may lose it. So the bleeding may actually be slight. It may be brownish or bright red in color, and the bleeding usually stops spontaneously. This is the key thing. It stops spontaneously. The pain shouldn't be increasing. There shouldn't be any significant pain. The bleeding also should not be increasing. Signs of these things increasing are bad signs. So the bleeding is usually painless, but there may be some mild backache, there may be some dull pain in the lower abdomen. On the history, what are you going to actually elicit? So there may be minimal perivaginal bleeding. So it may be fresh blood with clots or brown staining. You may have little to no abdominal pains. You may have some fetal movement still being present. No products of conceptus have actually passed. And when you examine this woman, you do a pelvic examination. The uterine size is normal for the dates and for the pregnancy. The uterus is soft. When you perform a speculum examination, the bleeding may be seen through the os, and of course the cervical ostium is closed. The fetal heart rate is present. The fetal movement sometimes can be even felt. This is a threatened abortion. It hasn't yet happened. Investigations that you would do: a full blood count to assess this patient's HB, and also cross-match this patient and blood grouping, so your ABO and RH incompatibility, because if this woman is rhesus negative, you would want to give her RhoGAM to prevent the condition of erythroblastosis fetalis or rhesus incompatibility. Then serum progesterone may be given depending on whether her levels are low, if it's available. You may also order for serial beta HCG levels to assess the fetal well-being. How do we manage a threatened abortion? So there is no medical management that is indicated. Tell the patient to avoid excessive work for at least 2 weeks. Pelvic rest, so there shouldn't be any coitus for at least 2 weeks, and they should get a follow-up ultrasound for 3 to 4 weeks. Give them analgesia for the pain. Bed rest. People really underestimate the power of a good nap or power of bed rest. So rest. 2/3 of the pregnancies will actually continue beyond well past 28 weeks. Some of them may actually progress and actually abort. What about an inevitable abortion? It's bound to happen. So here they're going to have heavy bleeding that keeps getting worse. There is severe colicky abdominal pain. There may be crampy pelvic pain. There is no history of passing products of conceptus, but when you examine this woman, the cervical ostium is open, and the products of conceptus may actually even be visualized at the cervical ostium. The uterine size is actually going to be corresponding to the gestational age of this patient. Investigations are quite similar, so your full blood count for your HB, your blood grouping and cross-matching, your ultrasound. So if this patient is actually less than 14 weeks of gestation, you may actually do a manual vacuum aspiration with analgesia. You may perform a paracervical block. Cover this patient on antibiotics, doxycycline 100 milligrams orally once a day, metronidazole 400 milligrams orally twice a day or 3 times a day for 48 hours in total. If it's greater than 14 weeks of gestation, so you evacuate the retained products of conceptus after the expulsion, you may actually give oxytocin to aid with the uterine contractions. 10 international units in 500 ml of normal saline to run at 40 to 60 drops per minute. You should send a specimen to histopathology and also karyotyping, and also cover them on antibiotics, the same regimen as these ones before 14 weeks. Counsel this patient, offer them a family planning afterwards. Then with a complete abortion, there is minimal vaginal bleeding. There is a history of them passing products of conceptus. The pain may have ceased or it may have stopped. Then when you examine this woman, the uterus is small and bulky, so the uterus will be contracted. The cervical ostium is closed. Investigations pretty much the same. So at FBC for your hemoglobin, your blood grouping and cross-matching, then your rhesus matching, and your ultrasound, which is going to be showing an empty uterus. So management here is largely conservative, bereavement counseling and family planning. And for all those women that were having abortions, if the woman is rhesus negative, do not forget to give anti-ROGAM, because you want to prevent further problems later on in future. Because if this woman has a man who's rhesus positive, then this may become a very, very big issue. So give them 50 micrograms for early miscarriage or 100 micrograms for late miscarriages, IM, within 72 hours of abortion. The same drugs, doxycycline 100 milligrams orally once a day, and metronidazole 400 milligrams orally twice or 3 times a day for 48 hours in total. Serial beta HCG titers should be done to ensure that you haven't missed an ectopic pregnancy. Then with an incomplete abortion, and remember that with an ectopic pregnancies, the levels of the beta HCG should be dropping. Then, or rather, if it's not an ectopic pregnancy, if it's an ectopic pregnancy, they will remain persistent, but you won't even be able to, if you're not able to visualize it in the uterine cavity, then it's most likely an ectopic way, if you have these persistent levels of the beta HCG. Then when it's an incomplete abortion, there will be a history of heavy bleeding that's getting worse. There is severe colicky abdominal pain, uterine cramping. You may also have some products, but not all of them, being passed. The uterus is smaller than the period of amenorrhea. The cervix is open, and the products of conceptus may actually even be passing through the ostium. Investigations include an FBC, blood grouping and cross-matching, because the patient may actually even be in shock. Get an ultrasound as well. What's the management? So we want to assess the hemodynamic status, and we stabilize this patient. IV fluids if they need, blood transfusion if they need a blood transfusion. Give them misoprostol 600 micrograms orally or 400 micrograms sublingual as a single dose. Bereavement counseling and even family planning. This is in the medical management. Surgical management, you may perform your MVA with analgesia. Of course, send the specimen for histopathology and karyotyping. Do not forget to offer bereavement counseling and family planning for this woman. And doxycycline 100 milligrams orally once a day, metronidazole 400 milligrams orally twice a day or 3 times a day for 48 hours in total. Then what if it's a missed abortion or a silent abortion? So this is fetal demise before the age of viability without expulsion of any products of conception. So the pregnant uterus actually fails to grow, and the signs and symptoms of pregnancy would have actually even disappeared. There may be a history of passing this dirty or brown vaginal discharge. No fetal movements are going to be perceived. The cervix is firm and closed. The uterus is smaller than the dates, and there are no fetal movements, no heart sounds. Investigations include full blood count for the hemoglobin, ABO and RH blood grouping, ultrasound to confirm that there is an absent cardiac activity and there's an empty gestational sac. If it's less than 12 weeks, you can manage it medically. If it's in the first trimester, we're going to be giving misoprostol 800 micrograms vaginally every 3 hours, a maximum of 2 doses, or 600 micrograms sublingual every 3 hours, a maximum of 2 doses. If it's 13 to 17 weeks, misoprostol 200 micrograms per vaginally every 6 hours for a maximum of 4 doses. If it's between 18 to 26 weeks, misoprostol 100 micrograms per vaginally every 6. It should have been every 6 hours, not every 6 weeks. This should have been every 6 hours with a max of 4 doses. Then surgical treatment in the first trimester, misoprostol 400 micrograms per vaginally every 3 hours or sublingual 2 to 3 hours before the MVA with analgesia. If it's in the second trimester, misoprostol 400 micrograms per vaginally 3 hours, or sublingual 2 to 3 hours before the MVA. And of course, the evacuation should be done ideally in theater under general anesthesia. Then send the specimen for histopathology and karyotype. Doxycycline 100 milligrams orally and metronidazole 400 milligrams orally twice a day or 3 times a day for 48 hours in total should be given. What about a septic abortion? So here they're going to have a history of a pelvic pain, fever greater than 38 degrees for 24 hours or more. They may have a purulent vaginal discharge or passing products of conception and possible pregnancy interference. So this is maybe in the background of them trying to commit an abortion. Then examination is going to show that they are pyretic for more than 24 hours, a very high fever. They have a maternal pulse greater than 100 beats per minute, low abdominal pain and tenderness, open cervix with a discharge. The speculum examination shows this malodorous vaginal and even cervical discharge. Investigations include a full blood count to check your HB, and even the white blood cell count may be changed. The ABO and RH blood grouping and cross-matching. Ultrasound to confirm that there are some retained products of conception. And of course, a bedside clotting time should be done. And blood cultures also can be done. Now, what's the management for this? So on admission, you can actually give ergometrin 0.5 milligrams IM or symptometrin on admission. Remember, avoid this drug in hypertensive patients. Adequate resuscitation is needed, so IV fluids and blood transfusion. Monitor the urine output. Admit them and start them on antibiotics. So these should be started ideally 8 hours before the procedure, and the patient must receive them for a total of 14 days. That's your ampicillin 500 milligrams IV TDS, that's 3 times a day. Gentamicin 80 milligrams IV 3 times a day. Metronidazole 500 milligrams IV 3 times a day. Then ideally, the manual vacuum aspiration should be performed by a senior because there's a high risk of perforation in these patients. Send the specimen for histopathology and karyotyping, offer bereavement counseling and family planning for this woman. I really hope you enjoyed watching this and you learned a lot about abortions. If you did, consider subscribing to the channel, hit the bell notification icon to be receiving notifications of such videos every time I post. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.